So yeah, Zoom is definitely the place to be connecting with each other. But we also have set up a Slido account, and throughout some of the presentations, there'll be some polls. It's also going to be where we're collating the Q&A for the session. So if you've got some questions as you're listening to the speakers, if you've got some burning questions that you want to put to them or to any of the other presenters, please use the Slido for the Q&A function. If you just hover your phone over the QR code or log into Slido and use the code on the screen right now, you'll be able to, if you've not used it before, it's pretty easy to navigate. You've got 2 tabs. One will be a place that you can manage the Q&As. You can see other questions other people have asked. So perhaps you don't have a question of your own, but you want to see what questions other people are asking. You can vote on the questions that seem most important to you, that feel most important to you. There's also going to be questions that the presenters are going to be putting to you as the audience. So it's a really nice way to feed back to the people that are going to be speaking to you today. And then once we've heard from all of the speakers, we'll be rounding up at the end just to let you know next steps. Next slide, please, Berenice. So to give you a bit of a flavour about what we're going to be talking through today, I should introduce myself actually. I'm the Regional Learning Coordinator for Social Prescribing across London. I'm based at the Bromley by Bow Centre. Big focus of my role is supporting link workers in their roles, and I run peer supports across London. And I think it's fair to say that there is no denying that the need for social welfare legal advice is on the sharp incline. And this is something that comes up in all of our meetings, all of our peer supports. So I'm really excited to be having this session today. I think it's a really, really useful session. We're going to be hearing from Sarah Bearden, who is the Partnership Models for Social Welfare Advice in Healthcare. She is doing a PhD at UCL, so she's researching around this subject, so a wealth of knowledge. Jo Goodman, I think many of you will know her from some of the training we do at the centre, but she's been doing a lot of work, a lot of research on the ground around what's happening in this space, practically on the front line. What are some of those partnerships? What are some of the challenges? Trying to get an understanding of how we're collating data around this so that we can inform commissioning. We're also going to hear some examples from practice. There's going to be some of your colleagues, some of your neighbours that are doing something around on this subject. We're going to hear from them, and then we're going to have time, about 20 minutes at the end, for Q&A. So as I said before, for those of you just joining, log into Slido, have a think about what questions you want to ask the presenters. That's where we're going to be managing the Q&A. Use the chat in Zoom for talking to each other, the Q&A function in Slido for queuing up some of those questions. So that's it from me. I think I'm going to pass over to Dan and Jagan. So some of you will know Dan. He's the Director of Knowledge and Innovation at the Bromley by Bow Centre, and as I like to call him, I don't think he minds, the social prescribing dinosaur of London. He's got he's been around for a really long time on this scene, and will be opening for us alongside Dr. Jagan John, who is the personalised care lead for London and an all-round advocate for social prescribing, and a hugely positive force for moving some of the activities in primary care to a preventative model. So I'm really excited to have him here today as well. So without further ado, I shall hand over to Dan and Jagan.
Thank you, Leanna. I think Jagan, you're leading, and I'm going to follow.
Great, thank you, Dan. Thank you, and thank you for inviting me. My name's Dr. Jagan John. I'm a GP by trade. I'm also the North East London Integrated Care System CCG Chair. and lead for personalised care across London, working for NHS England. So, and thank you for coming. It's really, really important part of our, movement. This is a really big part of our recovery, particularly from the pandemic, and also I would see that as almost developing our future narrative for how we as the NHS and our partners work collaboratively together to support the most important part of our society, our residents and our patients. So from my experience, we've seen that having our social welfare advice, as well as our social prescribing working collaboratively together, we in my own GP practice and across Northeast London and across London, we've seen some fantastic improvements in the way that not only our patients interface with the NHS, but also determining their long-term future plan for their own lives, but also the way they interact with services. And what we have seen is that, it is always sometimes a bit of a learning, even for us as medical professionals, that we don't really we actually underestimate the importance of the impact of the longer or the bigger social determinants of health, which is things like poverty, housing, debt, all those kind of things, that has a profound effect in the way that we not only manage our day-to-day practice, but also the way we manage the medical conditions that are attributed. And we've got various examples, and you're going to hear some great case studies today, which really kind of puts the set. Are we really addressing the right things in the NHS? And are we addressing the way that we manage the future of the NHS collaboratively? So just to give you an idea of the kind of issues that we have, the health expectancy, the gap between the most deprived and the most well in terms of socioeconomic terms, is about 19 years. And I'm not going to preach, but there is such a higher risk of death, low birth weight, shorter life, obesity. I call obesity the social or the silent marker of deprivation, chronic disease, diet-related problems. You're 3 times more likely in a poor or poverty side of your life to have mental health. You're twice as likely to have long-term conditions. And in terms of health behaviors, there is lots of evidence in terms of smoking, alcoholism, as increased in those areas that have those poverty within their own areas. So, and it affects, for example, the employment, parenting, education. If you have debt, you're less likely to study. And people don't realize the profound effects on the NHS. Your did not attend rates increases dramatically in areas that have poor socioeconomic factors. Your ability to access general practice, for example, and primary care significantly reduces because the GP appointments increases for those groups of patients that have that need support. And in terms of health inequalities, if we look at those areas, the NHS doesn't really very well determine or actually address some of those issues. So what we do need to do by looking at this as a collective group is about moving to the prevention agenda. How can I get someone to not have those long-term conditions? How can I have that we are actually focusing on holistic care rather than focusing on problem-based care, which is what the NHS does. And I will say that if you look at the national statistics, 1 in 3 up to 1 in 5, and I suspect it's much lower and it's much worse now, are in touch with poverty across the system. So if I include drug compliance, prescription charges become prohibitive, compliance to drugs and medication becomes prohibitive, and addiction is much, unfortunately, increased in those socioeconomic groups. So there's something about us getting to a point where we really embrace the social welfare advice, prioritizing those patients who really need those support and having the ability to do that. Now, as a GP, I don't traditionally have that support unless I go through, in my patch, through our link workers who are part of the council that have those debt people part of that organisation. But if you can imagine now, when I ask some of my colleagues across London, the numbers that we have to deal with are huge. So there is something about, because of the fact that we've got these massive waiting lists to deal with it. So I'm not going to go on to too much further, but we need to have this conversation together about having this welfare advice within our primary care sector, within our primary care networks. We also need to think about, from an integrated care system, if we truly are integrated, we should look at all the social determinants, which unfortunately the Marmot review did also talk about some years ago as well. And I think for us, we have a role in the NHS for advocacy to try and champion our patients' roles, but we also have the unique ability to design something collectively together that allows access to the people that need it the most. Thank you, Dan.
Great, thank you, Jagan. And I think you've really summed this up incredibly well. But just to sort of think about the journey of the last couple of years, there's been a real rethinking about what shapes health and well-being within communities. This has led to the universal adoption of social prescribing within the NHS. The idea that we have link workers now for every primary care network, and that number will be increasing over the next couple of years. The messaging to clinical teams within primary care that identifying social need is really important, and referring on to social prescribing link workers is absolutely critical. I think the next stage of that journey, if you've just talked about, is this idea of the holistic care within communities, the need to ensure that people have access to social welfare advice and the services that will provide for them to have, good food, good housing, good employment, good levels of income that allow them to live healthily, green communities and sustainable communities. We see all of this as part of this, understanding of what sustains health and well-being for our communities and for the individuals within it. And critical probably in this next stage, if we think about what's happened now in the last 12 months, of course, COVID has really shone a light on health inequalities and, if you like, on socioeconomic inequalities as well. And there are, a number of mantras that we hear talked about, build back better, and one that Michael Marmot has championed, which I think is really important, which is build back fairer. And how do we, and the GLA, we know, are completely behind this in terms of the recovery missions. And one of their recovery missions is around this idea of creating a safety net for Londoners. So as we move into the next phase, if you like, of the next few months leading into the kind of subsequent sort of 12 and 24 and 36 months, thinking about what London needs in terms of these recovery missions, providing really professional, accessible social welfare and legal advice within our communities becomes absolutely critical. And as you and I were talking about earlier this morning, Jagan, trying to ensure maybe that every GP practice or every primary care network in London has a social welfare advisor attached to it, providing advice sessions, not just in a high street venue, but also within those health centres themselves, will become really, really important to ensure that our community gets that access, including, of course, we know that the furlough is going to come to an end in the early autumn, and some of the moratoria around debt and and payments of rent and so on will come to an end as well. And that will undoubtedly see an increase in the need for really good advice. So this is a critical agenda for the recovery process for London. And it comes at the time when the integrated care systems are just forming, and this provides a great opportunity to bring this together to really support our communities in London. So today's session is really critical in that context. I'm now going to hand back over to Liana, who's going to take us into the next session of this morning, which looks at some of the great practice around how social welfare advice and social prescribing and primary care are working together, and will give us some real inspiration in terms of how we build these systems and collaborations going forwards.
Thanks, Dan. And I feel like there's so much there, and I know that we could probably do a whole session on kind of the integrated care systems, the direction of travel, and why this is such an important time for social prescribing. But I think if we can all have one takeaway there, it's that we start using the phrase "build back fairer," and really highlight the important work that Michael Marmot is doing in driving this agenda forward. Really pleased to introduce Sarah Bearden. As I said before, she's doing her PhD on this topic. She's been looking at 9 in-depth case studies and is going to talk through some of her findings. So welcome, Sarah. You're on mute.
Sorry about that. Just had to unmute. Can you hear me? Can you hear me now?
That is wonderful.
Yep.
Yeah. Okay, so thank you very much for the introduction. I'm Sarah Bearden. I'm a PhD student working at UCL, and I'm working across both health and law, and specifically focusing on the partnerships between healthcare and legal services and how those are implemented. So this work grew out of my previous employment with the UCL Centre for Access to Justice. And during my time there, I produced this report which mapped out the services across England and Wales that provided assistance for social welfare issues in healthcare settings. And I was really interested by what I found in that report, just partly because there was such a range of different approaches, and also because I noticed that the partnerships varied quite a lot in how closely the health and legal teams worked together. And while some of them had been around for decades, others were really turning over quite rapidly. So I was interested in the delivery side of things. And I wanted to know how these partnerships could be implemented successfully. So that became the question for my PhD work. And obviously it's quite a broad one, and there are different parts to the study that I'm doing. So the work that I'm presenting today is the practical field work that I've been doing to understand the operation of these partnerships in a bit more detail. So I've been working with doing a comparative case study with 9 services across England. And I've been collecting the data through interviews with members of staff. That includes the legal advisors, health and social care professionals, as well as the managers and the funders. And I'm taking a qualitative approach to analysis. I should say I'm about halfway through that now. So what I'm presenting today is my early findings and also initial thoughts on recommendations. So all of the services I worked with provided assistance with social welfare legal issues, mostly welfare benefits, debt and housing. They were all casework services, so they were able to support people to quite an in-depth level if that was needed. And they were all linked with healthcare, either physically or remotely. So firstly, I'm just going to take you on a quick tour of the case studies to give you a sense of the main design features. I actually chose these services for diversity, so I wanted to look at different health settings and different service models and also different regions of the country. So there's quite a lot of information on these slides, but you will have them to come back to as well. So my first 4 case studies were in primary care linked with GP practices. And you can see here there's quite a range in scale. So the ones on the left were covering whole counties and local authorities linked with almost every single site. And then the other ones were much more localized. They were all face-to-face services except number 3. So what number 3 had done was actually to place telephones in GP practices so that patients could simply pick up the receiver and be put through to the advice team. And that allowed them to cover a much wider region than they would normally have been able to do. And where there were multiple sites, the normal thing was to have a kind of rotation session, so usually a weekly session with appointments in each practice. And there's also, you can see a range of different funding sources here, which included local authority, NHS and university funding. So my next 4 case studies were hospital-based in care for children, for cancer, mental health and HIV. Number 5 and number 8 were single site services, but actually patients were coming from really wide regions to access those because they were quite specialist care settings. And number 6 and number 7, those were county-wide, so they had multiple sites to cover, and that included hospices and adult mental health teams. These were all face-to-face services, and again, where there were multiple sites, the advisors would be rotating around them to cover the region. Again, a range of different funding sources here, including charities. And I also just wanted to highlight a couple of unusual features. So number 8 was a multidisciplinary team. So that was actually a single welfare rights officer that was employed as a member of the care team. And I think that was perhaps the closest way of working that I observed. And number 7 was actually a multi-agency partnership. So this involved the NHS working together with 5 local mental health charities to join up care across the region more effectively. One of those was the Advice Charity, and the way that they had embedded it was to have an advisor in each care team who was like an integrated embedded worker in the team. And my final case study was also a multi-agency partnership. So this involved local charities coming together to form an independent third sector enterprise. And it was set up to support all of the health and social care teams across the borough. The legal advice part of it was delivered remotely. So referrals actually came into a single point of access, which was a telephone line that was manned by welfare rights advisors. So at the first point of contact into that partnership, any welfare issues would be picked up, but the advisors would also assess for other needs and would be able to connect patients with the wider support available in that partnership. And this one was jointly commissioned through the NHS and the local authority. So I noticed some interesting things in terms of the patterns across the case studies, how they were designed and operated. So firstly, in terms of referral sources, it was interesting that across all of my case studies, actually doctors didn't seem to refer very much at all. You'd get some, of course, but largely the referrals were coming from other places. So in primary care, this was largely self-referral, word of mouth, and signposting quite commonly from receptionists. And in the acute settings, the big referrers were hospital social work departments, nurses, psychologists, information and support centres like PALS and Macmillan centres, and the hospital discharge teams. And it just seemed that these were the places that patients were asking for help more commonly, or that were already doing some kind of social assessments that would pick up on those welfare needs. The second thing is about accessibility. So it's important, of course, that the services are equitable in their access as much as possible. There was one particular service in primary care that was only open to registered patients at quite a small number of practices. And so most people in the borough actually couldn't access that service. It can obviously be quite difficult with limited resources to cover everywhere. But it is important to think how to open those services up to everyone, including potentially just linking in through primary care networks. I think the remote services had a little bit of an advantage in that they had a real wide reach without necessarily needing huge manpower. And certainly they were very convenient and accessible for lots of people, I think. My concern would be that they might not reach particular groups of people. And I did work with services where the patients didn't have phones, they didn't have access to the internet. Some of them had communication difficulties. And I would, it might be worth just considering whether there are certain groups who might need face-to-face provision as well alongside that. The other challenge quite commonly was demand, and many of these advice teams were quite small, so couldn't take unlimited referrals. So what some of them had done was to focus on areas where the help was most needed, for example, particular departments within hospitals or areas of particular deprivation. And some of them had also drawn on volunteer advisors and pro bono advice to help boost the capacity of their teams. So I think in terms of service models, if you were developing a new service, I think my recommendations would be to consider who is best placed to identify need in those settings that you're working in and link in with them for the referrals. Also to consult with key groups in the design and development of the services, and just to make sure that that service is accessible and working well for both the patients and the staff. And also just to encourage some kind of local needs assessment as a basis for the design, to try to focus on where the needs are greatest if you have to make some of those difficult allocation decisions. So my next question, what makes for good collaborative working between the health and legal teams? So I'm firstly going to describe the different activities that they were engaged in. So in all of the case studies, the teams were making and receiving referrals and exchanging information if that was needed to support the casework. So for example, somebody's information about somebody's health condition. And sometimes that was all they were doing, often in the primary care services and the remote services where the staff weren't coming into contact with each other so much. But in acute care, the teams were working very much more closely together on a day-to-day basis, and they were more actively involved in identifying needs, in coordinating input into the cases. So for example, they might be discussing responses together, feeding into joint support plans, sometimes meeting patients together, doing ward rounds together, that kind of thing. And also providing feedback to each other on a person's progress so that their care could be better coordinated. And I also noticed that the advisors became almost like consultants for the health and social care teams and would be helping them to understand the welfare laws and how to respond to welfare needs when they arose. Generally, actually, in all the teams, the relationships seemed really positive, a bit stronger in some places than others, but engagement in these joint activities could be quite variable. It could be quite difficult to get people kind of making referrals and exchanging information, that kind of thing. And some of the services also had stories to tell about quite negative attitudes and obstructive behaviour. So I've been looking into what are the things that influence collaborative working between the health and legal teams. And currently I've broken it down into these three broad themes. So people needed to be willing, confident, and able to work together. Under willingness, it was clear that people were engaging more when they felt the service was valuable for their patients and for themselves, so where they really perceived a need for it. And also where they felt personally responsible for doing something about those needs. And it wasn't always the case, so some healthcare professionals would be feeling that it wasn't necessarily their job. Under confidence, I noticed some interesting things as well. So often in the early stages of the partnerships, there could be some issues with trust. So staff thinking, who are these advisors? You know, what are they doing? Will my patients be safe with them if I make a referral? And also certain healthcare professionals not feeling very confident in their own knowledge of welfare, of how to identify and respond to welfare issues, not knowing necessarily how to raise things with patients and have conversations about these welfare issues. And under being able, I'm including here practical things like having opportunities to actually work together and communicate, and having the right administrative procedures in place to enable that, and also having the right information and training available so that people knew how to engage. So in terms of recommendations, of course, you can't really force people to work together, and it really has to come from them. But to encourage it, I think you can try to create environments that are conducive to collaboration by providing opportunities to work together and get to know each other. And you could also try to address some of the barriers to collaboration. So whether that be knowledge barriers, physical barriers, or administrative things. It also often helps if you can have someone that can broker the relationships between the agencies as well. This sometimes takes a bit of work and a bit of encouragement, and some leadership from higher up really goes a long way there. And particularly if that comes from within the health service, because that helps to kind of inspire confidence in the service as well. So my next question is, what influences sustainability? So I've been looking at the pathways that the services have taken, how long they've existed, and whether or not they've been able to continue. And this typology here describes the different trajectories that I have observed. So the ones on the top left have been around a long time and are still going. But I have to say, even for these ones, it's not been a smooth ride. There have been lots of ups and downs along the way. The ones on the top right have unfortunately come to an end despite a long lifetime. On the bottom left, we have the newer services, which seem to be doing really well up to this point. And on the bottom right, this one never really put down roots or continued past the pilot stage. So I'm still working on the analysis there to understand what is influencing these trajectories. But there are some things that are quite clear already in terms of how resourcing decisions are being made. And so I wanted to mention those. And actually, I think you can break it down into the same broad themes as I mentioned before. So funders' willingness to fund was a really interesting one. And obviously different types of funding organisations will have different goals, and therefore they will also have different expectations of the service. And sometimes that was a very neat fit and aligned really well, and at other times I think that was slightly more strained. Another thing I noticed was that funders of all kinds often doubted their responsibility to fund, even if they actually valued that service really highly. So for example, local authorities would be saying, this is a specialist health role, therefore the health service should fund it. The NHS would be saying, well, this is not healthcare, this is welfare rights, therefore the local authority should fund it. And often the charities were asking themselves whether actually they were subsidising something that ultimately should be state funded. So these doubts were really common, but where I did not see that were the projects that were jointly funded, and they brought together different resourcing streams. And I think perhaps that is because in those places, the responsibility was collective. It was a joint effort. In relation to confidence, this was whether the funders had the evidence they needed to show that this was a worthwhile service. And they could be getting this information either through evaluations that the services were doing, or through feedback from colleagues, and certainly the services that were very well known and very well promoted tended to do a bit better in terms of the confidence of their funders because they had quite a high profile. And in terms of ability, sometimes no matter how much a service was wanted, there sometimes just wasn't the cash to cover it, or there wasn't the physical space to host it. And that kind of thing could obviously be quite final. And unfortunately, one of my case studies was actually cut last month after 30 years. That was a welfare rights funded, so local authority funded service, and the local authority has just become so short of cash that it couldn't cover it. And unfortunately, the health service also couldn't pick it up because of the extra expenses that they're having with COVID. So they just couldn't really cover that role. But I think often there is some flexibility in those things, particularly if organisations can pull together and each contribute a little bit. And so in terms of sustainability, I would recommend, if possible, to seek out joint resourcing and support in kind, partly just to draw on all the resources that are available, but also to develop that collective responsibility that I just mentioned that was so important for the stability of these partnerships. Also focus on evaluation and promotion to build that confidence and awareness in the funders. And I would say also possibly develop and strengthen leadership. I really noticed that certain people had played a really critical role in sustaining those services simply because they were such active champions of it, and had really kind of drummed up support and influenced those strategic decisions, even if they themselves weren't really in a position of much power. So my last question, what difference did the partnerships make? So the field work that I've been doing has largely focused on the implementation rather than the impact of the partnerships. But if you're interested in the evidence base, one of the first things I did during my PhD was to review the published evidence from across the world about the impacts of health justice partnerships. And at the end of this presentation, I put a link to where you can find the draft of that paper. But during my interviews, I was listening to people's experiences and hearing about the difference that these partnerships were making for patients and staff. And I was interested in how this related to the different service models and the activities that were going on. So today, just for time reasons, I'm going to focus on the difference this was making for patients. So it was really clear that improved access to advice was one of the benefits everywhere. Patients were finding their way to assistance more easily because they were being referred or signposted or simply seeing information in the healthcare setting and making their own way. But where there was more active engagement from the health and social care teams, that effect was actually strengthened because the needs were being identified more consistently and referrals were being made at an earlier stage. In terms of welfare, again, extremely positive outcomes everywhere, and it was clear the advice services were achieving huge financial gains and other benefits for patients. But again, where the teams were working more closely together, that effect was strengthened because people's needs were being communicated effectively, and also the medical evidence could be obtained that increased the success rates of those claims. It was clear that those positive welfare outcomes were having a real benefit for mental health, and that's also reflected in the literature. So at the very least, this was taking a weight from people's shoulders and reducing anxiety levels. But at the other end of the spectrum, I was also working with services where patients had committed suicide because of benefit reviews or had been so destabilized mentally that they were on the verge of hospital admission. And I think for those people where vulnerability to mental health vulnerability was very high, this was literally saving people's lives, and that's what people were telling me. The last thing to mention is patient experience. Again, I was hearing lots of positive things about this, and partly just because the services were there at a critical time. So when people had real needs, often resulting from illness, but potentially not the strength to battle with the welfare system. But also the transitions were really smooth for patients. It was easy for them to get help because the service was right there in their healthcare setting or just a phone call away. They didn't have to go and start searching for assistance. And also the help they were getting was very tailored to their needs. And I really noticed that the advisors I interviewed in these settings had become quite expert in health. They understood healthcare conditions. Quite often they knew the treatments and the side effects. They knew exactly what information to put down. And with the support of the medical teams and the medical evidence, they were really able to provide the best possible support. And I think that was particularly important where you had groups with quite stigmatized illnesses like mental health and HIV, who were actually not opening up to anybody outside of their care team. So having an advisor on that team was just incredibly supportive and meant that they would get help that they would not otherwise access. So as well as interviewing people, I also asked my case study services to send me any evaluation reports that they were doing, just to get a sense of what they were achieving, and also to see how they were going about evaluation. And this slide shows the types of things that they were measuring. And you can see that largely it's looking at processes and outcomes, so much less in the way of impact evaluation, but that's because impact evaluation, it's very challenging, it's time consuming, quite often it needs some research expertise. But the services actually were quite keen to be doing that, and many of them were actually looking for support with it. Mostly though, the funders, I have to say, were very happy with the evaluations that they were getting based on the process and outcomes. And from that, they could see that the service was reaching the people that they wanted it to reach, and that it was achieving significant benefits in terms of welfare for the patients. And very often that was enough. But it wasn't always enough, depending on the goals of the funders. And unfortunately, one of my case studies was decommissioned partly due to a lack of impact evidence in relation to health status and service use. So being able to show that these services were improving health and reducing pressure on healthcare. And I think we certainly need to improve the evidence base for this further, and we could do with some more high quality studies. Obviously, that doesn't need to be everywhere, but if we could work with a few key sites to develop some of this research, I think that would be great. So my recommendations in terms of evaluation, firstly, for the services, I would simply say evaluate according to your funded goals. Make sure you know what those goals are and feedback the information to show that you're meeting those expectations. And very often, a simple evaluation will be enough. In the long run, though, I think it would be really useful to have an evaluation framework and some guidance to make it easier for services to design their own evaluations. And in terms of the impact research, it would be great to see some more work using routine healthcare data. I think you could design some quite neat, quite robust studies that way, tracing things like health status and service use, which, as I mentioned, are really key outcomes and something that lots of people want to know. And if you knew those things, you would also be able to model the financial return on an investment from the healthcare perspective, which is very much sought after from the commissioners. So to conclude, I would just like to re-emphasize that these findings and recommendations are very new. It's only in the last couple of weeks that I've kind of consolidated my thoughts around some of this stuff. I still have more work to do on it, and over the summer I will be consulting with my stakeholders. And if you would like to feed into that, please drop me a line and I'll be very happy to include you. But to end on some reflections, I think in some ways it is quite a difficult time for these partnerships, and I have seen them decommissioned and broken up as social prescribing rolls out. And also based on some of the conversations I've had with funders, I know that COVID has actually impacted on the income streams of many of these funders. So I think it could be quite a difficult time. But I also do think it is a time of opportunity, and I'm really encouraged to see that London is leading the way here and recognising the role of social welfare in health. And I think, as our speakers earlier mentioned, in terms of the general direction of travel for the health service, it is very much more towards more local collaboration and not just in primary care. So we may see some more interest in developing these partnerships. So a big thank you to my supervision team, and also thank you everybody for listening. There is my email address if you would like to get in touch, and also the link to the Open Science Framework where you can find some of my unpublished work. I'm very happy to take questions if there's time.
Sarah, what an absolutely epic piece of work. I think I'm getting lots of messages from people saying how wonderful the webinar is and how useful the reflections are. I think there's a couple of questions that came up in the Slido, and for those of you that have joined the webinar later, please do go on to Slido and post any questions that you have for our speakers in there. You can all vote on which questions you want to, which are going to be the priority for you. You answered some questions around funding and measuring of impact. I think there was a question around lack of knowledge around GPs and how we can encourage more direct referrals from those that were dealing with some of the patients in primary care. Is that something that you can speak to?
I can try. I mean, unfortunately, I don't have enough interviews from doctors to be able to piece that together entirely. But certainly, I mean, largely it wasn't that they were negative about it. I think most people were they really understood the importance of this. It was more that it wasn't really on their mind. They didn't necessarily have a lot of time to think about it. And certainly one of the things I noticed in primary care was that there was very little opportunity to actually interact with the advisors. A lot of the advisors that I spoke to actually didn't know the GPs at all. And they were saying, in the GP practices, everybody works in separate rooms behind closed doors, and there just isn't that space to be able to have the conversations because I think a lot of the education and kind of awareness raising just happens naturally as people talk to each other and have those conversations and educate each other and discuss cases. And I think, I don't know the answer for how to make that happen, but I could certainly see some of the barriers there in primary care, both in terms of opportunities to interact and just potentially just not thinking about it. And also they have 10 minutes with somebody. I mean, that's really difficult. I think if a GP came across an issue they thought was a social issue, I think they would more naturally refer to a link worker, because they don't have to think too carefully then, is it a welfare issue? Is it something else? And I think that's one of the benefits of the social prescribing approach. And in one of my case studies, there was an overlap with the social prescribing scheme, and it was a little bit confusing for GPs. They didn't know who to refer where. But in terms of how to improve it, I mean, certainly trying to create some space where those conversations can happen, but also providing some learning opportunities. I'm not sure if GPs would have time to do this, but some of the services were doing interesting things like just allowing health and social care professionals to come in and sit and shadow advice sessions and just see what went on and to understand that a little bit better. And as I said, having somebody to help kind of build those relationships and broker those conversations a bit can really help, you know, making sure that the advisors are invited along to the meetings, for example, because I know those meetings they do take place, but often the advisors are not there. And so I think, yeah, thinking about some of those barriers.
I've got no doubt some of this is going to come up in some of the case studies we're going to hear from later, and I think there's some good suggestions coming up in the chat. Jagan and the guys from Merton are suggesting bringing some of the those that are looking after the social determinants of health, bringing those into the MDT meetings. I think one of the things that we always say at the Bromley by Bow Centre is that, you know, the GP is probably the most trusted person, and Craig's asking a question about is there any evidence, do you see any evidence that stigma in relation to accessing advice was reduced in healthcare settings? Obviously it's a really important place to catch people, and I think I really also enjoyed your plug for encouraging link workers that they need time with patients, and as targets are pushed up and pressures on services are increase as the demand increases and people start to understand what social prescribers are doing, I think they're being put under pressure to reduce their consultation time, and I think it's really, really important that that is ring fenced and that link workers have time with clients in a way that GPs don't. But I'm interested, sorry, to hear about your thoughts on stigma and maybe how it shifts in a healthcare setting.
Well, I was certainly hearing about that from my interviewees. Remember, they're the member of staff rather than the patients. And it is also reflected quite strongly in the literature, if you want to go and have a look at the literature review that I've done. And certainly people were telling me that patients find it's more anonymous. It can be quite difficult for patients to go and seek advice on high street if they feel that would be a bit exposing. Whereas if you're in a GP surgery, somebody, you know, they would just assume that you're there to see a doctor. And also, say for example, it's a domestic violence issue, you can always tell your partner you're going to the GP. You can't necessarily say you're going to the Citizens Vice, or, you know, can't be seen to be going there. So I was certainly hearing things about that. And certainly, you know, those services working in HIV and mental health for those people that weren't seeking help elsewhere. And partly, I think, for fear and kind of anxiety and stigma issues. I certainly heard about that.
That is, yeah, it's all really interesting. And if please feel free to post the link to the any publications that you're referring to in the chat so people can have a look. Someone gave a very good suggestion to bring Amanda into the conversation. Amanda is at Law for Life, and it would be great to hear from Amanda about the Advice Now programme. If you've got a couple of minutes, Amanda.
Certainly, yes, thank you.
Feel free to pop your video on.
I can do that now, can I? It's not letting me.
No worries.
No worries. Yeah, start my video. Here we go. Right, I'm Chair. Thank you very much, Fiona, for this opportunity, and so wonderful to hear Sarah's presentation on her research and see her again. Hi, Sarah.
Hi.
Law for Life, which is the charity I chair, is a public legal education charity. We help people to acquire the knowledge, skills and confidence to tackle the problems that life throws at them, many of which are legal problems, but they don't see them as legal problems. They see them as unfairnesses, or people being discriminatory, or people just being horrible to them. We've been running housing rights courses funded by the Ministry of Justice in the southwest of England, and we're about to run it in the northwest of England. We've been amazed by the response from social prescribing link workers. We've been totally oversubscribed, and they're all saying how useful this is and how many of the issues that we're talking about are issues that come up in their day-to-day interaction with people. Housing rights is amazingly complex. Welfare benefits rights are amazingly complex. These are things where you really need a qualified social welfare law advisor. But if you can't find one, our website Advice Now brings together resources from right across the web. So it includes citizens advice, shelter, lots of other specialist resources, but we also fill gaps with our own very detailed guides. And our guides are designed to help people who can't access a lawyer or a welfare rights advisor. So some of the things we've got that are really helpful, I think, for individuals, but also those who are supporting them, family and friends, professionals and volunteers. Our welfare benefits suite helps you with appealing PIP decisions, paused at the moment, but when those come back, that's going to be a huge issue. We have a special tool which helps people request a mandatory reconsideration for PIP and for DLA. And we know from the feedback that people who've been in despair about ever getting their needs recognised have actually done much better using our tool. We also know that professional welfare rights advisors use it because it speeds up their job and it means they can help more people. We've also got a service of what we call affordable advice for family issues, because you may see many people whose employment, housing and debt problems have exacerbated their family problems. And we now have a new service which is called Affordable Advice, where you can actually book a short, low-cost consultation with a family solicitor right at the beginning of your consideration of whether to get a divorce or a dissolution of a civil partnership. That's hugely important. We've also got stuff on pension rights on divorce, which is, again, a really tricky issue and one that's going to plunge millions of mainly women into poverty if they don't do something about it. So these are resources for people who are digitally and cognitively capable, or for those who are supporting them. And that's, I think, what's so important for social prescribing link workers. We would love to do more housing rights courses for more groups of link workers and social welfare law advisors. And so if you'd like one, get in touch with us, but bring your funding with you, because we're a tiny charity and we can't do this as a loss leader, unfortunately. We can also do awareness raising courses for people, groups of people who actually need a sort of guided tour of the Advice Now website to help them understand what's there and what they would find most helpful in their daily working lives. One of the things we developed for mental health patients in Woolwich was a guide to avoiding benefit sanctions. I read it and I thought, you need a master's in administration to do this, but we've written it all down in one place, so it's helpful for people. Leanna, thank you very much for that opportunity to talk about what we're doing.
It's so wonderful and it's really good to hear from you. So thank you to whoever suggested that in the chat. I'm going to come on to, we're going to hear more from Sarah in the Q&A, hopefully a bit later on. But going to come on to Jo. Jo's been working at the Bromley by Bow Centre and has been doing some research into some practical case studies around social welfare legal advice being integrated and collaborating with social prescribing. So without further ado, I shall hand over to Jo.
Thanks very much, Leanna, and thank you, Sarah. I feel like a bit of a fraud claiming to be doing research after Sarah's research, as this very much isn't to the same PhD level. But yeah, just to give a little bit of background of what I've been doing over the past few months. So this piece of work followed on from the research report that some of you will be aware of that Bromley by Bow released in January, focusing predominantly on co-location of social prescribing and social welfare advice services in health settings, primarily in primary care. And following on from that, particularly the pandemic has obviously thrown a lot of those kind of co-location approaches slightly into crisis, with lots of people not being co-located even with their own colleagues, let alone with other services that they might have been working with. So what we have really aimed to do has been to look at different models of collaboration, whatever they may look like, whether that's co-location or whether that's something slightly different. And also to look at the experiences of social prescribing schemes on the ground, whether or not there is actually a really active collaboration with advice services going on. And we also wanted to try to examine what the data looked like in terms of the evidence of the kind of existing need that was there before the pandemic, but also kind of how that's changed over the course of the pandemic. And a lot of what comes up, and Sarah touched on this, around funding for these kinds of services is very much reliant on the data that's there to evidence the need. So we were really interested to look at what kind of data was being gathered through social prescribing, which might evidence the need and the changing need for social welfare advice services. So we've spoken to people in 11 different boroughs across London. As I said, some had specific services in place, others didn't. All of them had some degree of advice going on in their borough, thankfully, but whether or not there was a kind of formal partnership going on or any funding dedicated to advice in health settings was quite variable. Ooh. So I thought I would try to do a bit more of my own research in this out of interest. So if you're on the Slido, it would be great if you could just switch from the audience Q&A onto the polls function at the top right. So if you are involved in social prescribing, whether that's on the front line or whether you're managing a scheme or whether you're working with a social prescribing scheme as an advice service, do you think there has been any change in the level of demand for advice on issues like welfare benefits, housing and debt? So do you think it's increased significantly, increased somewhat, decreased? I will give you, I'll watch the numbers ticking up and see when to stop this. I can see the way it is going. Okay, give it another 10 seconds or so. Okay, so it's looking quite clear that, what's that, about 90% of you are saying that there's been some kind of increase, and most of you are saying that that's been a significant increase, and that is very much aligned with what people that I spoke to said. And second thing I'm interested to know is, if you're working on the front line as a social prescriber or an advice service in a health setting, or you manage a scheme, what kinds of issues are you seeing the most? So can you rank these issues in terms of which you're seeing? So I think you should be able to just move them up in order to rank them. Please shout if that doesn't work. Always very paranoid with Slido. Okay, starting to come through, that's reassuring. Okay, bit of movement around the top. See where that settles. Okay, so that looks like it's settling with housing and welfare benefits at the top. Housing potentially looking like it's coming out at the top, which is something that's been reflected quite strongly through the conversations I've had, and I know some of the conversations Leanna's been having with link workers, but debt up there as well. And interesting knowing that, you know, there are a lot of protections in place at the moment around debt and housing, which are to be lifted over the coming months, so whether that's going to shift even further. And how easy do you find it to access support for your clients needing social welfare advice? Again, if you're not on the front line, just give your impression of how straightforward it is for social prescribing link workers in your area. moving around. Let's see where that's going to settle. Okay, so again, it's looking like actually this is quite a mixed picture. So I'm actually very reassured to see that the top two responses are that it's been somewhat or very easy, but clearly there's a substantial proportion here who are finding it a bit more difficult. And I'll talk a bit more about what I found from talking to people in a moment. And if you're involved with a social prescribing scheme, how would you describe the data you hold on the demand for social welfare advice in terms of the quality of that data? If someone were to ask you, how much demand do you think there is for social welfare advice in your area, how easy do you think you would find it to demonstrate that? Okay, again, this is looking quite reassuring. So most of you saying, well, about half of you saying good quality, and the next most common answer being very good quality. So yeah, actually it looks like it's, yeah, you're feeling relatively confident on that data, which is brilliant. And if you are a link worker, have you ever found yourself helping with advice issues that you felt went beyond your job role or your knowledge level? This is the last one, sorry, I'm going to stop making you actively participate very shortly. Okay, that's staying quite steady, interestingly. Wow. Okay, so that's looking like over 90% of you have felt that you've had to do things that go kind of out of your comfort zone, or it's just dipped under 90%, but it's around there. And that's, yeah, it was very useful to have Amanda's overview of the Advice Now website as a point of reference, but clearly there are some major challenges here. Thank you everyone for participating in that, and we will download the answers so that we've got that as a bit of additional data, so thanks very much. In terms of the different models of operation that I found in my conversations, obviously co-location is one where advice is based within or integrated into primary care. Because I was talking to social prescribing link workers, it was very much focused on primary care in this case. In some cases, there were models where there was reserved capacity, so things weren't necessarily co-located, but there was specific capacity of advice workers that link workers could refer over to, rather than relying on signposting to services which, as we've already heard, are often oversubscribed and can sometimes be a bit challenging for people to access, particularly if they're in vulnerable situations. Lots of models of collaborative working and trying to make referral pathways as clear and straightforward as possible. So some examples of the kind of multidisciplinary team approach and ways of ensuring that journeys are as smooth as possible for patients. Lots of places that are working on training and capacity building of link workers to try to ensure that they're able to identify issues as effectively as possible, potentially give initial information or help with low-level issues, and knowing how and when to refer across. And just in one place, we found an example of a kind of combined link worker advisor role, where more holistic support was able to be given by that link worker without the onward referral actually needing to be made. The key challenges, which will come as no surprise after Sarah's presentation and some of what we just saw there, rising demand for advice services, both through health pathways and wider referral routes, and anticipation of that continuing further, particularly as some of the protections like the furlough scheme and moratoria on things like evictions are lifted. In some areas, if there weren't particular schemes in place, there were real challenges accessing services for patients. In others, I should say that even where there wasn't a strong relationship, the advice services were still clearly doing a sterling job with really unprecedented demand and challenges of working remotely to meet those needs. But in some places, it was clear that waiting times had increased, and also actually where link workers were trying to help resolve issues themselves, that they were struggling sometimes to get through to statutory services like housing departments in local authorities, for example. And some of that was meaning that in some places, link workers were finding themselves forced to hold complex cases, which went beyond their training level and caused capacity challenges, because clearly it takes a longer time to work with someone that needs that in-depth level of support. And if you're not trained to deal with it and you're having to navigate things without the knowledge, and possibly until now not knowing that Advice Now existed, then that causes some real challenges for people trying to navigate quite complex systems. In terms of data and demonstrating demand, some people I spoke to had really robust systems in place that demonstrated the level of demand, and they could compare figures from before and after the pandemic hit. In some cases where they were working with an advice service, the advice service also specifically had that data on what kinds of things they were seeing coming through directly from social prescribing. Largely, the people I spoke to reported that between 50 and 80% of patients they saw had some kind of social welfare issue, which is clearly really, really high levels of need. And in all cases, I think those kinds of issues were some of the most frequent prevalent issues that were coming through the door. In terms of the challenges with data, some of the things we found were, in some cases, there were quite broad data categories used, which sometimes made it a bit difficult to tell which things were definitively advice related or which kind of advice it relates to. So, for example, often things like employment was a heading, but that's quite difficult to disaggregate because that could be an employment law advice need. So someone who's being paid below minimum wage or experiencing harassment or discrimination in the workplace, or needs information about their rights in relation to the furlough scheme. But it also could be someone who's facing unemployment and is looking for employability support. Even things like money, which you can probably say is clearly an advice need, it's not always clear what kind of advice that is relating to. So it could be welfare benefits, it could be debt, it could be someone that needs money management or financial capability support. Differences in data systems mean that sometimes, even if there's really robust information in one place, it's quite difficult to get that at a borough level or to kind of compare between boroughs, because the way that data is recorded can be quite variable. And another challenge is that one of the key parts of the data that we were looking at was the onward referral data, but that doesn't always paint a true picture of demand. So, for example, if a local advice service is already at capacity and isn't able to support people with basic form filling, for instance, which ideally would be something that an advice service would be able to help with, it might be that the onward referrals are only being made for really complex cases that those advice services are able to have the capacity to take on. So it's not always possible to look directly at the onward referral data to understand the demand, because in many cases link workers have actually adapted their referral behaviours based on what they know about local service capacity. So that's kind of enough of me rabbiting on. What I really wanted to do was enable some of the people that I've spoken to who are doing really interesting things in their boroughs to share a bit about what they're doing on the ground. So I'm just going to double check what order I said I would call on people in. So the first person who I'm hoping is here and able to share is Jackie from Barking and Dagenham. Are you here, Jackie?
I am, yes.
Great.
I'm just trying to hang on. I don't know how to put my video on, but right, okay, now I've worked it out. That's right. I'm not used to Zoom. Oh, hello.
We
right,
can hear and see you. That's great.
Right, okay, brilliant. So I haven't got anything to share because I've got 2 minutes, is that right? To share something. So we've basically, with our social prescribing model, we're a local authority service. So within the local authority, we've got something called our Homes and Money Hub, and that's a real partnership service which is comprised of local authority staff plus sorry, get a cup of tea in the middle. Homes and Money Hub caseworkers, benefits reviews, job centre plus people, and they work really closely with Citizens Advice Bureau and other voluntary sector organisations like DABD and The Source. So they work on a whole range of issues around sustaining people's tenancies, looking at money and debt issues, welfare benefits, and general debt reduction. So we've got a relationship manager model where these GPs will send a referral into the social prescribing service, and if there's money and debt or housing issues that have been identified, we've actually got local authority. They're basically based in the same department as us, so we've got real quite quick routes into those services to get support for people. So there's a very kind of, it's not like a referral, it's a warm handover. You're sort of co-working on a case with somebody. So that's it in a nutshell. I don't know if I've said too much, too little, but
thank you, Jackie. That's perfect. And what I should say is that everyone you're hearing from, we have written up case studies of what they do, so you can get a bit more thorough information and read up on it a little bit more. So yeah, you're getting a little taster of this, and hopefully we'll be able to dig into it a little bit more following on from the webinar. So thank you very much, Jackie. That's great. Next, can we go to Sarah Burns in Croydon?
Good morning, everybody. Yeah, so for our case study, essentially, it's when link workers came into post, it was kind of a little bit fragmented in Croydon, in that we had link workers employed by all kinds of different providers and some by the PCN itself. So as the VCS kind of infrastructure body in Croydon, we thought the best way to provide support and better interconnectivity with link workers was to put on some support for link workers. So we started with things like, thankfully, the first lockdown hadn't happened by the time we managed to get everybody out on a walkabout in their local PCN area. We've got 9 PCN areas in Croydon. So we were able to, we have colleagues that are based in the community, that know their community well and follow the asset-based community development approach. So these community builders walked alongside link workers, getting them to know their local active citizens, local community groups that they needed to connect with, and of course their welfare advice, their specialist support groups that they need to rely on. And the reason more about building relationships, building proper interconnectivity, and when people come along with all the kind of multiple challenges that they do, we're able to support them with who we know that has capacity. One of the main challenges, of course, sorry, can you hear me? My internet connection looks a bit shaky. Can you hear me?
It's cutting out slightly, but we can generally get the gist. Yeah.
Oh, brilliant! Sorry. Yeah, I think the interconnectivity, the relationship building is what's at the heart of it. So we've done a lot of kind of support for link workers in that sense to essentially come along with us in the approach that we're already taking, which is that asset-based community development approach, starting from what's strong in people, looking at that kind of can-do, what can you do, what can you build on, what does a good life look like for you, what are your next steps, what can you do for yourself. So we wanted to kind of take that approach within Croydon, and so we did that by a number of things. We kind of heard from link workers about what their strengths were, what their challenges are, where their training needs were, and put a programme together. And a lot of it, you won't be surprised, number one came up as housing, needing housing. To be able to know what to do when people come along with housing support, and then where to get that specialist advice from. So we brought groups together in the area, not only the statutory body but voluntary colleagues, to kind of give advice to the link workers about what they can do and when to look for specialist support and what's there. And so we've done that in a lot of different areas around debt, domestic abuse, all the kind of areas that you've already mentioned. And I think one of the key kind of what we learned from all this is that trying to bring everybody with the shared vision is one of the key things, how we can best support community resilience. There is this, and people have mentioned it in the chat quite a number of times, is that kind of disparity where there's funded link workers but no funding for the no additional funding for the welfare advice groups that are were already underfunded prior to lockdown, and now are really struggling to be able to provide that support that they so want to. And we there's multiple there's multiple ways that we can evidence that they're doing such a terrific job, but in Croydon we use Simply Connect, which is now London-wide through the GLA, and that has case management tracking on it. But again, one of the challenges, and I'll finish here because I know I'm rabbiting on, but one of the challenges being that because the link workers have been employed differently by different providers, some of which through a very medical model, they're not necessarily getting on board with the tools that we have as a borough, and some are still using the kind of Excel spreadsheets or straight onto EMIS, because that's what's known within a GP setting. Sorry, that was a whirlwind, and I know I've raced through and not said half of the things I was going to. But
thank you, Sarah, and yeah, hopefully people will be able to have a read of the case study and get more information. But thank you very much. If I could hand over now to Helen Price from Enfield to talk a bit about the approach that you've been taking.
Hi everybody. Yeah, so I'm the manager for social prescribing in Enfield, delivering services to 2 large PCNs, and specifically around social and welfare advice. We already, so just to clarify, the social prescribing link worker model that we're working to is the NHS one, which has got a very specific defined scope, which doesn't think it's about link workers connecting people to services, not particularly doing any of those things for them. However, in Enfield, we have a gap around advocacy services due to the shrinking funding over the last few years. So some of our link workers have been involved in doing what we would call advocacy work, helping people fill out forms and so on. And we've allowed that to happen because we're trying to identify the scope of the advocacy type of role service that's needed in order to fill the gap. But I just want to share very quickly with you my screen, because we in Enfield, can you see that? It's a diagram with enablers in the top left hand corner. Yeah, good. Okay, and Jo Goodman has got this. I've sent it to you, Jo, so she can share it with you as part of the case study. So we have a national lottery funded Health Champions programme in the borough, which was set up in 2019 and was designed before the social prescribing, the NHS social prescribing link worker stuff all came out. And the key thing about this is that we, as part of this programme, fund a full-time post at the Citizens Advice Centre in Enfield, and that post is there so that we can fast-track members of the community into support around socio-economic issues. Now, the Health Champion Network is meant now to be the community sort of part of the social prescribing, supporting people in the community aspect. So social prescribers can also fast track their patients, their cases, their residents to the Citizens Advice Service. And we are finding that housing and debt obviously are the 2 top things that people are accessing information about. EVA also is part of a project in Enfield around debt management, and that funds another half a post at the Citizens Advice Centre in Enfield. So that's how we've linked up, and we've identified some funding through the Integrated Care Partnership System work that is currently in the process of being looked at for use within the community, and that will be something hopefully that will be continuation funding for the Citizens Advice connected model to the social prescribing and health champions programme.
Thank you, Helen, that's great. Last but not least, I'm going to hand over to Phil Vasey in Newham.
Great, Helen, you can stop sharing your screen.
Yeah, I'm just trying to do
Yeah.
that.
Okay. Hi, everybody. I've got a slightly different model. So I'm a public health consultant in Newham, and all those I came in during the poll bit of the discussion, Joe, at 11 o'clock, and all those issues around debt, employment, housing, including preventing eviction, immigration, support and advice, early years, family support, all those things have escalated during the pandemic. We could have predicted that. And in Newham, we need a far greater army than our brilliant social prescribers and other link workers. So in September, we formed a cross-sector project team to work on 2 North Stars, if we can have 2. The first one was the training of all frontline workers in the borough who may intercept a resident in or heading into crisis. So that includes social prescribers, food bank managers, teachers, GPs, faith leaders, that whole frontline workforce in the borough. Second North Star is working on warm referral routes. Really good to hear other people use that term, because we know our most vulnerable residents can be complex and will need wraparound support. So the case study that you've got, Joe, is all about the first bit of that, the training element. And in November, we started to offer 5 themes: core conversations, how do we build the trust of residents, housing and homelessness, finance and employability, working with migrants, and early years and family support. And we've even added new courses around mental wellbeing support for the frontline workers. So we feel that's really important. Themes this current quarter are drugs and alcohol addiction, London living wage, domestic violence. And as of yesterday, we've had 709 attendances on the training program since November. So really, really exciting stuff. It's all in the case study. The next time you're going to invite me to talk to you, hopefully, will be about the polls that you just did, Joe, because we've been working with the London Borough of Hackney with 350 frontline workers on precisely the sorts of questions you were asking, and it's going to set our KPIs for our warm referral pathways work. So some really exciting stuff. It was brilliant to see those polls. That's the Social Welfare Alliance in Newham in a snapshot.
Brilliant, thanks so much, and I'm sorry for making you all stick to 2 minutes, but that's been really fascinating. Thanks so much, and hopefully everyone will be able to read the case studies and get more information.
Is it back to me? I'm just looking through some of the questions that are coming through. We've run out of time for a proper Q&A, but I wanted to give a bit of an overview of some of the things that people are talking about, because I think what this whole conversation has really thrown up or highlighted, and I think Sarah touched on this, is how we fund this work. We know that there is a need. We understand that link workers have got insight into the needs on the front line. All of us seem to be in agreement about what those needs are, and how do we go about making some of the services that are responsible for the social determinants of health, how do we bring them onto the social prescribing agenda and make sure that they are being funded so that our link workers have got services that they can be referring people onto? Dan, I'm not sure if you're still around, but I wondered if this is something, is he not? Yeah, I wonder if there's anybody else that would like to speak to that agenda. Is Jagan around?
I can, Leanna.
Yeah, please do, Jagan. Have you got, what are your thoughts on that?
Yeah, so I think it's a really good question, but and I think part of the integrated care system is actually focusing on these things, because these are problems for the local authority as well as it being a problem for health. So this is actually a great thing. This is the right time, as across London we're trying to form these integrated systems. These are the kind of things that need to be brought to the same, to say, how do we deal with this collectively? And I think, and that will include the finance bit. So it's interesting when listening to some of the schemes, and I thought, oh, I'd love to have that. Oh, I'd love to have that. You know, it was those kind of discussions to say, oh, that's a good idea. And, you know, you know, there are multiple things, but I think part of this dialogue and part of the importance of having this kind of discussion, and in some respects just listening and reading some of the services out there, is actually exposing what people are doing so that they are part of the narrative. Because unless we're aware of it, we can't have those conversations in those integrated care systems to say, actually, we have great schemes. For me, those will form part of the financial discussions to say, what are we going to do? How are we going to find? It will be a bigger issue. There'll be things like voluntary sector funding and all lots of other things as well. But
and actually, I'm just thinking as well, Jagan, as we move to the integrated care systems, I'm guessing that the ICSs are going to be working much more closely with the local authorities. We've got a local authority representative here, Phil, as the
Leanna, I was going to thank. So I don't see this as a health. I don't see this as purely in your health domain. I think if we do that, we will. You know what's the pandemic taught us in East London? It's that the systems actors, so the health partners, the VCS, and the local authority, and others have to work together to solve the big issues of the day. And if you guys in health think you're carrying the weight on your shoulders, reach out to the voluntary sector. There, you know, there's a plethora of services there. The local authority has lots of answers as well. And unless we tackle this together, you know, last week I chaired a session at Homeless Link around, you know, immigration and health rights, and the two GPs, they spoke as if they had the weight of the world on their shoulders, and they did, because they weren't reaching out to other players in the system. So I don't see this as a narrow social welfare and health issue. I see it as a systems issue across the whole borough.
And
I think that's where, sorry, just to come in on that, I think Sarah's point about that kind of shared ownership and collaboration being the path to sustainability, I think that's been one of the real challenges for advice services if you take them out of health for a moment. And I know we've got Dal from Advice UK here, who I'm sure would have lots of interesting input on this, but historically advice has been something that is absolutely critical to the delivery of so many statutory services, but in funding terms kind of falls between a number of stools. But I think if we are able to kind of leverage all of the interest in this area and get people working together, I think that has to be the only path forward, really.
You took the words right out of my mouth. You were literally reading my mind. I mean, this is going to be written into, you know, the way that we manage our systems locally anyway. I think the next steps, we're going to put a feedback form into the chat. Berenice is going to do that. We'll also send the slides, and everything will come as after this event. But my feeling is that the next steps from this is to pick up on some of the conversations that we're thinking about. Social prescribing, the impacts, we won't know about this. We won't know about some of the direct impacts of social prescribing and those interventions for a very long time. How are we going to be able to talk about the story of this intervention in a compelling way? How are we going to better link up and work collaboratively with other stakeholders that are charged with the same things that social prescribing link workers are looking at? How are we going to bring health and local authority and the voluntary sector together in a meaningful way so that we can tackle some of these things together? A really fantastic session, a huge thanks to all the people that contributed, and for those that were waiting in the sidelines if we had some time. Thank you so much to all of the participants, the people that have come along and shared their ideas and their questions. Keep in touch.
And just to mention that you will be getting an email following on from this with links to Sarah's research, to the case studies, also some funding that's coming out from the GLA on scoping out collaboration around advice in community settings locally. And hopefully this won't be the last of these sessions, so great to see so much interest. But yeah, now that we've got your details, you will be kept up to date with what's going on. So thanks so much, everyone.
Thank you.